Thanks, everyone. Thank you for being here. Can you quickly just show of hands the epidemiology students? Okay, great. It was really fun for me to put together this talk, and I had you in mind when I was doing it. So I'm going to ask you some questions. Anybody can answer, but I'll try to look at you for your thoughts. They don't have to be correct. I just want to have an engaging time with you. So thanks, Sadiq, for introducing me. So a few just objectives about the next 45 minutes together, and I want to talk for no more than 45 minutes and have time for questions and comments and thoughts from all of you. I wanted you to get to know me just a little bit because I'm brand new to UAB and really happy to be here. I want to give you a bit of some foundational information about the state of HIV prevention in the world, and then to think together about research methods and different study designs and comparison groups that we're turning towards and changes we're making to advance science and be able to move a product to widespread availability. I'm going to talk about implementation science and how this field, this relatively new field, really avails itself to sub-studies within clinical trials and within traditional epi designs to answer really numerous and important questions. And then we'll end by grappling just a bit with some study design questions in the field today. So to get to know me, this slide is a bit about my career briefly. So I was born and raised in Rhode Island. The top left is an old casino building that was in my town along the beach. I was not a very rebellious adolescent. My rebelliousness came when I decided to join the Peace Corps after getting my undergraduate degree at Boston University, and went to a very rural location to be a volunteer working in health, which mostly was diarrheal diseases and malaria and guinea worm eradication. I really loved that experience, the work and the life there. And so decided to do a master's in public health, which I did at Tulane University. I also really at that point had a bit of interest in HIV from undergraduate classes, but a lot from living in Burkina Faso as the epidemic was really starting to roll out and take hold in the cities there, and people in my rural village were hearing things and rumors and very scared of what they thought might come. And so I studied HIV and HIV prevention during my MPH, and then I went to do HIV surveillance work in Zambia, and I was a fellow with the CDC for 3 years. That was also very interesting. On the right, I did a study with sugarcane workers at a sugar farm, which taught me that I thought that research was very interesting because you've got books and papers to tell you how to do it, but it's different in every study, and a lot of it is making things up so that you can be precise and accurate according to a protocol, but it's not the same for any study. I'll give you an example. We were collecting dried blood spots from men so we could test them for HIV, but flies kept landing on the dried blood spots, and that wasn't good. And so we used food nets to cover the dried blood spots so they could fully dry and then be shipped off to be tested. So it was this kind of creativity that I didn't know existed within research that I thought had to be super precise and according to a protocol. So I also realized that I was missing a bunch of skills, and I went back to do a PhD in epidemiology. Also, like, very clearly I wanted to do this in 4 years and get back to the field and not get stuck in an academic setting, and here we are. I really loved University of Washington and my colleagues there, and so grew from that PhD program to do a postdoc and gain a few more skills in implementation science, really thinking about it from a global health perspective, and became faculty there. One thing that I didn't know it was possible, but there was also flexibility in that. And when my husband said, "I've landed my dream job to be a director of the Peace Corps," I said, okay, well, let's see where this goes. And they allowed me to live in Lesotho for 3 years and then to live in Belize for 3 years, maintaining all the things, the research, the teaching, the mentoring, and being on faculty and being a really active faculty member while I was living away. So that's what happened. And then in 2022, in July, I was presented with this amazing opportunity to join you all and lead the Center for AIDS Research here. And so that's where I am, and I'm having a wonderful time getting to know this space, both the UAB, the trainees, the faculty, and then all of the partners, the community partners, the academic partners, the state public health partners. It's been wonderful to have this time to do that. So my research portfolio is, a lot of it is related to to studying daily oral PrEP, which is a pill a day for HIV prevention. And I'm gonna go through that a lot in this talk. I also have a lot of my work is focused on HIV prevention within the continuum of reproductive desires. And I'm not gonna draw that out too much today, but I've done a number of projects with people who are going through different phases of being pregnant or wanting to prevent pregnancy or wanting to become pregnant or postpartum, and thinking about what that means for HIV prevention. But I want to just ground us first and make sure that, because we're a diverse set of interests. So just a few slides from UNAIDS and from the local government here about HIV. HIV continues to be one of the biggest massive epidemics that we have in the world. I'm going to focus today on East and Southern Africa, where we have the largest number of people living with HIV. And also the largest number of people who were newly infected over time, and especially including last year. But just want to focus for a little bit locally and make sure that everyone's aware that the state of Alabama is one of the so-called geographic hotspots in the U.S. There's 48 counties and seven whole states where more than half of the HIV diagnoses occurred in 2016 and 2017. And these data are the foundation of a huge national initiative to end the HIV epidemic in the U.S. Now, if you look, annual infections in the U.S. have begun to decline, the new HIV infections. And this shouldn't be surprising, I don't think, to any of us, but if you look at a breakdown of race among who became infected in 2019, the largest proportion of people are Black or identify as Black or African American, and this, clearly does not represent the whole proportion of people in the U.S. who are Black or African American. So there's tons of work to do. What I've always loved, what has always drawn me to this field is that it's not about a virus only and the pathogenesis of that virus, but it's about society and how we think about people living with HIV and how we provide care and services for them. So, but let's turn to HIV prevention because that's really what has really drawn me to this. And so when I think about HIV prevention, I have this analogy that we're building a toolbox. And in that toolbox, I think of a lot of biomedical strategies, some of which we have, some of which we have almost, and some of which are still really theoretically possible, but we don't yet know how to do it. And so we have pills, a couple pills and a vaginal ring. We have condoms. We have an injectable. I'll talk a little bit about that at the end. And then theoretically, we also could have films and implants and even infusions and suppositories that could prevent HIV infection and could work for people who have different risks and different ways that they are exposed to HIV. These are the things that we think about in this toolbox. I showed you those on my previous slide perform different forms of PrEP or pre-exposure prophylaxis. Other things that we have are HIV counseling and testing, and just the action of being counseled and having an HIV test is prevention for some people. We have condoms, we've had them for a long time. We have treatment of other sexually transmitted infections, which can help to reduce someone's susceptibility to HIV infection. We have syringe services programs and opioid substitution therapy for people who are exposed through sharing of needles. We have male circumcision. We have, and I'll talk about this a little bit, but not directly. We know now that when people living with HIV are treated and sustain their treatment, they have so little virus in their body that they're unable to transmit their infection to other people. And so that's as hugely important as it is for treatment, it's hugely important for prevention as well. I'll talk a lot about PrEP. I won't talk very much about PrEP. This is post-exposure prophylaxis. And then we've been desperately trying to develop a vaccine for decades and are not very close, unfortunately. So let's go into the research a bit. So what is PrEP for HIV prevention? Anybody want to offer some ideas?
So, pre-exposure prophylaxis.
Yeah. So the acronym stands for pre-exposure prophylaxis. It's probably not for everybody, but people who may come in contact with, may be exposed to HIV. It's pills. It's 1 pill a day. And so the top picture is from South Africa. The South Africa National Department of Health put this out probably 5 years ago. Taken daily, PrEP is an additional prevention option for HIV negative people. And here's a picture of it. Now, the pill, the blue pill there is a pill called emtricitabine tenofovir, which is a pill that's been used for HIV treatment for a long time. So there was a lot of data on it that it was safe, that it was pretty easy to take. And so the idea was, can you give this pill, that's for people living with HIV to control their HIV virus, can you give it to people who don't have HIV? And will it prepare their bodies to encounter HIV and then prevent them actually from acquiring infection? And so that was the concept. And so it was a pill already available. By the time these trials and these data were finished, it was almost off patent and able to become a generic product. So that all of that made it very, a very good candidate for these first trials. There are also, people, we knew that it worked to control HIV in people living with HIV. We had data from, we also had data from primate models where we could see that it would prevent infection. We also had data from mother-to-child transmission studies, so we knew that if a woman took antiretrovirals, she would not transmit to her child. So we had a lot of precursor data that made it seem plausible that this could work. We had no idea. There was complete equipoise in the field about whether it would work, but there was a lot of optimism and people decided to go forward with large phase 3 efficacy and safety trials. Now, one of these happened to be done by led by the 5 people shown on this slide who were my mentors during my PhD. And so I was a student doing my PhD, research assistant on the data team doing backup coding in SAS for a lot of the data on this trial. Who knew that I would love them so much and really love this area so much and that it would provide such opportunity for me. But in this trial, we were working with serodiscordant or serodifferent couples, which means you have a couple, a real life, stable, often married couple, in this case a cisgender woman and a cisgender man. This trial was done in Kenya and Uganda. They recruited 4,758 couples, which means that you're following close to 10,000 people because you've got to follow both of them in the trial for 3 years, which means that they screened like 20,000 people in order to enroll this trial. The amount of work and the amount of data is extraordinary. So each HIV negative person in the trial was generally healthy, and they were randomized to one of 3 arms. We were going to test this pill that was tenofovir only, test this pill that was emtricitabine and tenofovir and together in one pill, that blue pill, and then have a placebo pill. And they were followed for 36 months. And the data, it's a randomized controlled trial. It's the same amount of follow-up per arm. You can get the very clearly from the number of infections, you can tell what happened. And you have 52 infections in the placebo arm, 17 and 13 in the other 2 arms. The survival curve on the left shows you exactly that. The placebo arm had incidence close to 5% per year, which is a substantial amount of HIV incidence. And then in the 2 active arms, it was much lower, closer to 1% per year. And so huge amounts of efficacy. These are some of the data that went to the US FDA. And in 2012, the FDA approved this medication. It was approved. They gave it a new indication. Now it could be used for HIV prevention. And so that happened. Yeah, Sarah?
Just
Pulling back the curtain a little bit, and I know this happened with vertical transmission, that they actually stopped the trial because it showed such a significant difference. That's just such a dramatic curve. Were there ever conversations to actually stop and?
This trial did stop early.
So the 36 months was early?
These are, they had enough people, so not everybody that was enrolled in the trial went to the full 36 months.
Okay.
And so some people did, but they didn't, not everybody did.
Okay. So how long were they projected to stay in the field versus like when they saw the difference?
It probably would have gone for another, I have to look back and see, and
Sure.
I have seen, and it's super interesting to see the data safety and monitoring and like the cutoff, each time.
Yeah.
There were probably, guessing here, 2 data safety and monitoring committees. This is a very interesting story. There was this, because the data safety and monitoring board met in, let's see, they must have had a meeting in June 2011. That was an unplanned meeting. They had their prior meeting, it had been maybe 3 months before that. And at that meeting, the DSMB said to the statistician, we want an unplanned meeting in about 3 months. This is getting close to our pre-specified boundaries, but it's not hitting them yet. And so they had this meeting, impossible to schedule with people, had to pay a bunch on the weekend. It was like a Sunday, and at that point the DSMB said, you've got to stop the placebo arm. What this trial did was it stopped the placebo arm and re-randomized everybody in placebo to the 2 active arms, so that they could continue collecting data, because a 2-drug pill versus a 1-drug pill perhaps has some cost differences. Really wanted to see, to be able to provide data for that. So that's how that happened. And it was a very interesting time. The data were able to be, quickly double-checked and triple-checked, presented at a big international conference about a month later. And then at the same time as so there were all these trials going on. This trial from Botswana, so the top 2 lines here presented data at the same conference in Rome, showing that in both trials the results were that the drug works for prevention. There was efficacy, slightly different numbers there, but it was also the same conference when the results of the ART trials for prevention were shown. It was quite a conference. So there were all these trials going on at about the same time. The Partners PrEP study was not the first one. The iPrEP study, this line here, which had been among men who have sex with men and transgender women, was the first one to have results, and they showed a 44% level of efficacy. One thing that we learned the hard way, I think, over time was that trials were showing, different levels of efficacy, and these 2 at the bottom are really important because they did not show efficacy. And they were the only 2 that solely focused on young women from sub-Saharan Africa, and so they really threw, I would say they threw everybody into a tizzy, because we were wondering, well, does this actually not work for young women? And there's been a whole body of research to try and explore that from immunology studies and tissue studies through behavioral studies, and really, and so and really the answer is that it does work, but you have to take it every day in order for it to work, and that's really hard. And if you are 18,
you have to get the true data from people,
and it's really hard to get. It's okay in clinical trials because you're in these placebo-controlled trials because you have the same amount of non-adherence in your arms. But if you're 18 and living with your parents and have this rattly pill bottle that's antiretrovirals that your friend or uncle who's living with HIV also takes, and you have to travel every month to a clinic to get another HIV test and another set of bottles, and it's a fairly big pill. It's like a vitamin-sized pill. It's hard. It's hard. It's really hard. So we could show that it worked, and we could also know that it's not the ideal product for everybody at all times. And so these studies line up really nicely. I didn't put data in here about how do you measure if someone's taking a pill every day, but we've done a ton of work to try and do that too. You can measure it in blood, you can now measure it in urine, and you can do it in a dried blood spot, which is pretty easy to collect and store and ship away. But it's been hard and still unfolding. So this is what we learned from those placebo-controlled trials of PrEP. So now though the question was, how do you move into real-world delivery? How do you get this pill out there? Fortunately, the pill's out there because it's being used for treatment. It's being manufactured to a big degree. It's starting to become available in generic, which is a huge problem that the field is facing with other products right now. But we leveraged this opportunity for a demonstration project, and I think all of us tried to wrap our heads around moving from a highly controlled clinical trial environment to a less controlled, although still not public facility, but a less controlled environment. And this was the Partners Demonstration Project, and this is here where I became a postdoc now. We recruited another 1,000 couples from the areas around 4 of our research partners, 2 in Kenya and 2 in Uganda. And in parallel to PrEP happening is another story about treatment for people living with HIV and our thinking about when should they start medication, and are those medications toxic and so they should start later, and lots of data onto that. And so this project was built with flexibility in mind so that the protocol and the way that we did things could all be responsive to national guidance for people living with HIV as the study rolled out. And so, and also really in mind that if you have a couple, the goal is it's wonderful for the person living with HIV to take medications to control their HIV. Those medications will then control their transmission to their partner, and that could be the primary prevention for the partner. And so we want to support that as much as we can. It doesn't work for everybody living with HIV, and it doesn't work for all phases of their life. And so within a couple, there's these periods when PrEP is a great solution. It gives immediate protection to the negative partner. And we've done a lot of behavioral work to understand too what it does for the couple and how it gives them both a chance to take pills together. They can support one another, and that has a great, those have advantages for the relationship also. A lot of our HIV prevention counselors along the way became couples counselors and used to talk about these HIV counseling sessions that drifted quite into couples therapy and things where they were not trained and were supposed to not go there, but you can't, that was part of the work. So our theory was that if you offered antiretrovirals to both members of the couple, you could, and we started with couples where the partner living with HIV was not using medications because they weren't medically eligible at the time or they didn't want to. And so we would offer them and work with them on their initiation of antiretrovirals. We offered PrEP to all of the negative partners for at least 6 months. And then after 6 months, we would start to talk with them about maybe you don't need this PrEP medication anymore. Maybe it's time for you to stop, or maybe it's time for you to pause and see if you need it. And what we saw, I think not surprisingly over time, was this picture unfolded. So at baseline, the dark blue is in the couples, those who had only PrEP as their primary prevention strategy. And that dark blue fades over time. And what picks up is the red at first, where the couples that are having both ART and PrEP. And then it gives way to the green, which is where they have only ART for their couple. Now, many people, a number of people chose to use neither. Some came back and forth, and I'm not showing you all of the details of that here, but this picture overall shows you what happened. Now, the other thing that we were interested in is, like, in this real-world situation, do you get the same impact on HIV incidence that you got in the placebo-controlled trial? And we didn't have a comparison group here. We have only everybody got the same intervention. So what we decided to do was use this, we had the placebo arm from the clinical trial that had ended about 5 years prior. Sort of contemporaneous, you can argue about whether that is or not. And we can talk about that at the end because we had a lot of arguments. But so we decided to go ahead, we're going to do these counterfactual simulations. We're going to take the people in that placebo arm, identify the ones who were from the same geographic locations and had the same sort of characteristics in terms of sexual behavior, HIV viral load, and the predator living with HIV, and use that group to do simulations and come up with an expected number of HIV infections that we would have seen in the absence of PrEP in these couples. So the simulations say 80, we should have seen 80. Well, we saw 4. So we thought, okay, this is, maybe the predictions are wrong a little bit or a lot, but that's a big difference. And when you, we put that into a model, it turns out to be a 95% reduction in HIV incidence. And so we did the subgroup analyses. It was high reduction in incidence in men, 97%, 93% in women, not a different amount. We looked at the younger folks, 95%. We looked at the folks whose partner had a high level of HIV circulating, again 95%. So kind of no matter which way we sliced this and diced it in different subgroups, we were seeing a high reduction in HIV incidence. We also used this, we had at one point 6 ancillary studies going with this cohort. And these are just data from one, which is a costing study that was done in Uganda. And so you start with the research-based budgets, and then you go and you try to identify every piece that's going into the research, and every piece of that, the research that actually would need to be done if it was in a public setting. So you still have to do HIV counseling and testing. You do that for the research, but you do that in a public setting. So that's a cost that is for both. You don't have to do a consent form in a public setting. So the time and the skill to do that can be removed when you try to extrapolate this to a public health facility setting. And we did time and motion studies where you time how long does a counseling session take, how long does someone spend with the pharmacist, how long does someone spend in each of these, and you do many of them throughout, and to try and come up with an incremental cost. And so what we figured out in this top row was that we were spending $408 per couple to do this 2-year intervention with them. That's what the research cost was. Then when you take out some of those things that are just research and wouldn't be needed in a public health scenario, you get down to other lower costs. You can change the salaries from the research staff salary to a nurse salary in a public facility. And so if you do all of these things, the least amount that it would cost was $92 a year, or $92 for 2 years of a couple. And then we also looked into this and what are those costs, what's the different proportions. And really the medication and the clinical monitoring, which is the lab tests, were taking up the biggest chunk of the cost. And so you can really say, well, this lab monitoring that was happening at the very beginning of rolling out of this drug that's very safe, is it necessary? And over time we've seen national governments reduce the amount of clinical monitoring that's needed. Really, the only thing that's necessary now is an HIV test. For people who are below 25 or below 65 and start out with healthy kidney function, there's very, very little benefit to doing additional clinical or additional monitoring. And so that's what's been happening. So to summarize from this study, here we showed that PrEP and ART use were very high. They were, I didn't show you the data on PrEP adherence, but we did test for tenofovir in people's blood. And it was high, but remember, these are HIV serodifferent couples where they know each other's HIV status, which is a very important population that's taught us so much, but is so different from most people's situations. And so here we see that adherence was very high. The ART initiation we saw also being very high and exceeding the experience in public facilities at that same time. And this idea of PrEP as a bridge and people coming off PrEP worked and was able to be implemented. So a question for you. When you move from a super controlled clinical trial setting to this kind of demonstration project or more into the real world, what do you expect to happen with your efficacy, with how well an intervention works, anything? What do you think, what would you expect to happen? Decrease, and why do you say that?
Because you're no longer in control of the situation.
Yeah, the investigators, you lose control, right? So, and that is what we all expected as well. A very interesting phenomenon has happened with PrEP. And so in the Partners PrEP study, we saw an efficacy of 75% in the clinical trial. In the demonstration project, it was estimated to be 95%, so it's going up. Now, in parallel, here's two other trials, and those were the trials in 0 different couples. Two other studies happened in men who have sex with men. The highly controlled, placebo-controlled trial in men who have sex with men and transgender women showed an efficacy of 44%. In a separate, later, open-label study among the same kind of population, men who have sex with men and transgender women in England, the effectiveness was 86%. So what do you think is going on here?
Selection bias.
Maybe, selection bias. What's the difference about what you're telling, what's in the consent form? What's different?
We don't know if it works.
Right. So, and selection bias too, right? Because what happens in your clinical trial, you're like, we don't know if this works, it might not be safe, the consent form is 50 pages. In these demonstration projects, you're like, it works, and I'm definitely giving it to you. In the clinical trial, you're like, we don't know if it works, you might get the placebo. There's lots of, and so who's coming into your trial, your placebo-controlled trial, are good research participants. They're gonna stick with it. They're gonna do what you ask. They might not need it. In these demonstration projects, now you're like, it works, we're giving it to you, and they're like, I need it. I can't access it anywhere else right now, I need it, and they come and they take it. And so I think that's why, so that's a selection. It's a select group of people who want it and can stick with it, and that's who we got in these open label studies. So in the public sphere, these data and others are all being reviewed by the World Health Organization. It was 2015 when, 2015 when the World Health Organization said you should add PrEP to your HIV prevention packages. It's not a standalone intervention, but we recommend adding it. In 2016, I was doing a lot of work in Uganda, and so it was late 2016 when we had clinical guidelines. South Africa and Kenya were the first. They were about a year before this. But and in the U.S., I took out the slides about the U.S., but the U.S. we had FDA approval in 2012. We had our CDC guidance was also in 2015, I think. So we were starting to see it. But in Uganda, we also saw an opportunity to study the rollout, and we decided one question was, if you roll this out and you leverage existing programs to incorporate it, would it mess up the existing program? And would it take too long? Would it be too complicated? What would happen? And in a partnership with the Ministry of Health, we got a chance to work with 12 public health clinics in Kampala, which is the capital city of Uganda, to actually test this idea. This team is highly skilled in working with couples. They're gaining all kinds of experience in other populations as well. But we maintained sort of that experience with the couples to launch this trial. And we were going to say, when PrEP was first being rolled out, it was an antiretroviral. And so the people who had experience with antiretrovirals were HIV providers. Now that's come back to bite us a bit, but because of the sort of framing of it, and you need to go to an HIV facility, an HIV clinic to get access to PrEP. That's changed, but that was the beginning of it. We've got these providers. Antiretrovirals are safe, but we've got providers who've got experience with them and side effects and managing side effects and helping people get through them. And so let's start it there. And so for couples, we worked with 12 public health facilities that were doing ART and had a lot of people living with HIV in their care. And now we said, well, we can help you reach out and do HIV testing for couples and bring the negative partner into your program, and we can offer them PrEP, and PrEP as a bridge to ART as we had been doing it. And so we designed, well, and so what we were gonna do is, I'll so these are just a map, 12 facilities around Kampala and the Wakiso area. And we designed this as a step wedge cluster randomized trial, which is more of an implementation science design. What happens here is, this is a good intervention that you want all the facilities to have. But in order to be able to put some research, but two things. It's hard, starting a new program at 12 clinics at the same time is hard. It's logistically complicated, it's hard. And so if you stagger the time at which they start the new intervention, then you can call before they start, that can be your control period. And after they've started is an intervention period. And so then you can leverage this to do research and compare your outcome in the control versus the intervention periods. And so that's what we did. We had a randomization event. The 12 clinics were randomized to either that were going to start PrEP either first, second, or third. And when it was time for them to start, they got training. All of the providers got a 2-day training in person on what is PrEP. They had a clinic walkthrough the next day to look at flow and think about how they were going to offer PrEP. They also got, we delivered PrEP medication to them. And then they had ongoing technical assistance from this team of providers, clinicians, and nurses who had been part of the clinical trials and were quite familiar with PrEP. And so we did that. We embedded a ton of other things too, which I won't talk too much about. But you have this design looks nice, and then you have reality. And so we collected baseline data on everybody. You do that first until you get enough. We knew we needed, what did we need? We knew we needed 326 couples, I think, enrolled in each period in order to be powered. And so you kind of go until you get your number, and then you can phase into the next step and launch your next step. And so that's what we did. Right here, it was pretty nice. We were like 6 months, COVID. But COVID, and then the last step took 12 months. But I'll show you that, we were still able to continue. For this, we ended up enrolling 1,381 couples into this. The demographic breakdown looks very similar to the other studies. And then and as you're looking at your data, you're looking not only, you want to check by step to make sure that you're seeing similarities in the people and in the baseline characteristics across steps. And so the first 4 facilities that started delivering PrEP during step 1, their uptake of PrEP was really high. It was really fantastic. And it stayed really high. And we don't, and then the step 2 is when 4 more facilities joined, and so those are the orange ones. And then step 3 were the last 4 COVID who started, they started in December 2019. And so, some differences in PrEP uptake there. But that's what you can see, like generally above 75% of the time we were seeing HIV negative people with a partner who they knew had HIV initiate PrEP. I didn't talk, another way that when you're working in, and these were, these data were all abstracted from clinic records in these 12 facilities. So we're getting sufficient data, but also pretty minimal data. And so these are discontinuation data that we've defined. Discontinuation was based on the pharmacy refill data, which is not a great way to define, are you using PrEP? It doesn't tell you if they're swallowing pills or not, but it tells you something about whether they keep coming back. And here's, we see about the green is people continuing on PrEP. So remember, these are 0 different couples, so we're expecting by month 6 that most of them are gonna phase off. We see pretty high levels of drop off early on, You can kind of see people flipping around a little bit. There's some people moving from, a lot of people moving from green to orange. The orange to green are people that are deciding to switch back on, or they missed their last, or they didn't come back in time for them to be counted in one of these calendar months to be considered staying on, and lots of things going on, but generally lots of discontinuation happening. Our main question though was, this was an ART clinic for people living with HIV, so having PrEP and having HIV negative people and their partners come in, was that going to disrupt the ART program and the success that they were having? The way that you measure, if you will, success within HIV treatment is whether people are virally suppressed, meaning that the number of copies of their virus are quite low. And so these are, I think these are the baseline data of ART initiation and viral suppression in these clinics. So we thought we could have ART initiation as one of our outcomes, but it was 100%. 100% of people coming in for HIV were initiating ART at these clinics, which is tremendous. The programs were working really well. So we pivoted and we said, well, we have a little bit of room in viral suppression. It's only 85% of people. There's a little room that maybe we can make better, or we could see it drop off or something. So that's what we used as our main outcome. Now the viral load data though are abstracted from medical charts, which means clinician has to say, oh, we should test you we should draw blood today. You should go to the phlebotomy room to have blood drawn, to have blood shipped to the National Central Laboratory, to have your results put into the national database, to have your clinic look them up and write them down in your chart so that we can then abstract them. We were able to get some of them centrally, but it's a long process. And I actually felt hugely successful that we were able to get 65% of the viral loads we needed. And as and it wasn't a surprise that we had a lot of missing data. And so as we're moving through and making great connections with the people leading these facilities and the clinicians, we were able to devise some strategies to figure out why some of the missing data were missing. And so you could get information that, oh, so-and-so is transferred to another clinic, and it's not a clinic in your study, so you're not going to have access to the data. Okay, that means, okay, some people are like, well, they died. Well, why did they die? Sometimes it was a vehicle accident. Okay, so it wasn't related to their HIV at all, and that was important information. And so based on what we could get information, we developed a system, I won't read this, but to impute whether or not we thought they might be virally suppressed and put that into our results. And so when we did that, we saw that in the control periods before the PrEP program was there, we had 82% of the partners living with HIV were virally suppressed. Once we combined all of the intervention data together, 76.7% of people were seen to be virally suppressed. And that's not statistically different. So what we concluded was, and we did all kinds of sensitivity analyses without our, we didn't use the imputed data. We said if you were missing, you were all virally suppressed. If you were missing, no one was virally suppressed, and lots of things in between to try and see how robust our imputation, or how our results how robust our results were. Everything was pretty consistent. And so we concluded that it was fine to integrate a PrEP program into these ART clinics, and it wouldn't be any benefit to your ART program, but it probably wouldn't sink it either, and that was important. One quick ancillary study that a PhD student led here was we were doing these technical assistance visits, and they would write down reports of what they saw and what was going on. These data ended up being pretty thin, what we could get from them, but she worked with the team to pull out, still using this CFR domain, which is the Consolidated Framework for Implementation Research, to look at these different areas and figure out what was being seen and observed when our technical assistance team was in the clinics. And the one thing that they worked on together that they decided was, from their experience, was had a high strength and was very important was whether or not there were these people called champions there. A champion would be one nurse, not somebody in charge necessarily, but one nurse who really believed in PrEP. And that nurse made sure that everybody through the door got an HIV test and heard about PrEP. And that nurse, it didn't have to be a nurse, but like, for example, that nurse would empower her colleagues. Like, look, that person, I might have saved them from getting HIV this week because I talked to them, and you could do it too. And so that influence was hugely important. And so this was a nice study that one of my PhD students published. And so here you have, three types of large research studies, all with the same population of serodifferent couples in Kenya and Uganda. And from the placebo-controlled trials, you get that it works. From the demonstration projects, you get people will use it and have protection. And then really from the implementation science, you get, okay, we can integrate it into programs and move forward, and the programs will be great. And so that's kind of what this shows. So I wanted to go back to this picture, and these are a bunch of products. And so here's the question for you though. If you want to study a new, so we have PrEP medication, daily oral PrEP, it works. So if you want to study a new product, what's going to be your control group? In the trial, in the trial I showed you, was placebo-controlled. People, we didn't know if it worked. Half the people got some, or a third of them got something that was nothing, but a sugar pill. Can you do that anymore? Sadeep says no.
There are some ethical issues there.
Yeah, huge issues, so you can't do it anymore. So, well, what can you do? What's going to be your control group now?
A already utilized medication.
Mm-hmm.
Benchmark.
Yeah, so you can make that pill can be your control group. Mm-hmm. Other ideas? What else can you do?
Interventions.
Interventions? What do you mean?
Yeah,
Say
to
more.
encourage them to take the medication.
So if you're
Yes,
going to use
behavioral
if
studies.
you're going to use that pill, it's not just giving them a pill, right? You really need them to take it. Mm-hmm. So you've got to talk about adherence and counseling and all of that. Mm-hmm. What else can you do? Well, I didn't put these slides in, but been working on a trial where we're going to try to measure incidence in the community and use that as our comparator. No idea if we can do it. Right? That's one thing. I wanted to just show you.
Is that based on public health, like Department of Public Health
Mhm.
data?
What's that?
Is measured based on Department of Public Health data?
Or using different incidents in different assays to tell you if your HIV infection is new or not. And there's an assay you can tell by the tightness of the virus bonds if somebody has a new infection or it has an infection that's longer than like 2 years. So perhaps that's an innovation that can help. The field is rapidly moving and changing, and this is a new PrEP method that's an injectable. It's injected every 2 months. And this is what this trial did. So it took your idea of giving people, making pills the control or the comparator group here. But what you still want it to be blinded. You still don't want people to know. But of course, so you've got, everybody's getting 2 interventions. You get an injection, and either you get a placebo injection or the real thing, and you're going to agree to take a pill every day. And if you're getting the active injection, you get a placebo pill. And if you're getting the placebo injection, you get the active pills. And so if you're going to agree to be in that trial, you're going to agree to do all of that. And there were 2 separate large trials that finished within about, or that both were stopped early, within about 6 months of one another, because of tremendous efficacy of this injectable PrEP. And so I'll just show you.
So is that a non-inferiority trial?
So one was a superiority trial and one was a non-inferiority trial because they were in different populations, and the populations were known to have different degrees of adherence. So the trial 084 is this one on the right. This was the superiority trial in HIV negative women primarily from sub-Saharan Africa, where we had those two first trials that had null findings. And so this was designed as a superiority trial. Yeah, it's a superiority trial. This trial among men who had sex with men who had better adherence in the clinical, the phase 3 trials of the pill was a non-inferiority trial. In the end, and so interpretation of these hazards are slightly different, but in the end, both trials fortunately showed the product works really well. The trials also showed these levels of HIV incidence. We all thought like, oh gosh, they're not going to take their pills, you know. But having an incidence of 2% per year in this comparison group in the women was really great, because the incidence in a high-risk population of young women, we were seeing things like 4 to 6% in other trials. So the people really adhere to their medications, both medications in this trial. It was really great.
Do you know how they've followed them up to get more information about what's happening with potential infections in the tail once people stop taking injectables?
I don't think we have those data yet.
Okay.
So I don't have time to go into it, but the injection is super interesting. It's super powerful. But if you've ever, the best correlate, if you've ever taken, first of all, an injection it's in there, there's nothing you can do about it. If you have an adverse effect. So the trials had a 5-week lead-in period where they were giving people oral doses of the cabotegravir to check for that. Then, you know, something wanes and it's no longer protective against HIV, but it's not completely gone from your body. And with HIV, the risk there is that you can be exposed to HIV and become infected, and you have this low level of drug pressure there and resistance. That's a time when resistance can develop. The pharmacokinetics of this drug show that it sticks around at those kinds of levels for like 6 to 9 months. And so in the trial, when people came off the injection, they were given a year of the pills to cover the tail for protection. But if you're choosing an injection and you miss doses or things like that, you've probably not gone out to get daily pills to take. So it's very hard, and we're all still waiting for those data to see exactly what we see. So this method was approved at the US FDA in December, and I'm terribly negligent for not having a slide to tell you it was approved in Zimbabwe last week. So it's been very exciting. It's hugely expensive. No one knows how to pay for it. It's unclear if insurance in the US will cover it. These are all the trials and tribulations. And it's a new product, so it's not manufactured at high levels. All these things that have to get worked out and will get worked out over time. But okay, we did this. So this was back to the objectives. I hope we had a little bit of fun going through this. And I'll just end by acknowledging some of my colleagues. These are both faculty and staff and students that have worked on these data that I showed you.